In this session, we will touch on the most common research methods used in clinical research. In part one, we'll be talking about types of clinical studies with particular emphasis on clinical trials, bias, and study quality. And in part two, on treatment effect, statistical significance and power, and meta-analysis and forest plot. Got sort of general overview of the types of studies. The key issue is whether the study has a comparison group or just one single group. If there wasn't a comparison group, then we call the study an observational study or descriptive study. And there are three types. Cross-sectional study, in which group of participants are studied for certain to answer certain questions, such as asking a group of GPs about their management of back pain or shoulder pain. Ecological study is similar but on a much larger scale and usually studies people within a geographical area or a country or a continent to look at their features within that area. And case reports are a much smaller scale on reports on cases usually of rare clinical conditions. If there is a comparison group, then the next key question will be whether an investigator was involved in assigning the exposure rather than the exposure happened naturally. And if there was an investigator involved, then this is called an experimental study. So somebody intervened. And if this intervention or the assignment to exposure was done randomly, then this is called randomized controlled trials. If it wasn't, then it is a non-randomized controlled trial. If an investigator was not involved in assigning to exposure, but still we have two groups, then we call this an analytical study. And it depends on the direction between the exposure and the outcome, we have three types. If we start by the exposure and we follow people up and we see what happens for a particular outcome, this is called a cohort study. If we start with the outcome and then we go back and look for information or data on the exposure of interest, then this is called a case control study. If, however, we study both at the same time, so we're not following them in time forward or backwards, then when we have two groups, it's called cross-sectional study. But this is analytical cross-sectional as opposed to the prevalence cross-sectional in which there is one group. These of the analytical type, because there was no investigator involved in assigning the exposure and the exposure happened naturally, they are also considered as type of observational studies. We had the same layout of the studies we had in the previous slide, but within slightly different context, which is the context of time. So you've got the timeline in the bottom of the arrows, time now, and then to the left is the past, retrospective, and to the future, prospective. And so then we kind of plot the studies as we'd seen earlier. The cross-sectional ecological case reports just point in time now. The clinical trials or the experimental studies, we start with exposure now and we follow people with time into the outcome. If we have analytical cross-sectional studies, again, we have two groups, we compare, but at the same time now. Cohorts, we have two types now. We have retrospective or prospective. Prospective when we have the exposure now, and then we follow people up in time. And the retrospective, again, start with the exposure in the past. So we look at the medical records of people who had smoking in the past, compared with people who didn't have, and then we look at their outcome now. And then the case control studies is always retrospective, two groups. We start with the outcome. We start with people who have heart disease, for example, and this other group, people without heart disease. And we look at the medical records and see the exposure to a particular factor of interest. What is the best evidence for whether a treatment is effective or not? A systematic review of randomized controlled trial. An RCT is the best evidence to assess treatment effect But the best evidence for that is to have a group of RCTs in a systematic review. And this leads us to the issue of hierarchy in the evidence. So the evidence comes in levels. Level 5 is low, level 1 is the top, and this is the pyramid. So you can imagine with relevance for clinical practice, for humans, for patients, animal research is very useful, but it's the base of the evidence, clinical textbooks and experts, and you so on. And the top is the systematic reviews of RCTs if you are talking about treatments. And if you have meta-analysis of these, then that is the best. So when you look for evidence for a question on a treatment, you really would want to find evidence in the literature coming from meta-analysis and systematic reviews. This is your best evidence. The same hierarchy here is put in text, and again you can access this online, and you got in the first column to the left are the types of questions you're asking: diagnosis, prognosis, or treatment. And then the following columns, the second, third, and fourth, are the levels from level 1, best evidence, then the next best, level 2, and so on. So what should I do if I wanted to know if coffee raises blood pressure? A research question. So this is an intervention, an experimental study, because I would want to answer that by intervening, giving people coffee and other group not drink coffee and see what happens to their blood pressure. You need to compare, so that's very important. Either compare with nothing, compare with something looks like coffee but not coffee, doesn't have the ingredient of coffee, or compare with something else which I might think might have similar effect but it is not coffee. I decide and I will justify my choice depending on the treatment. So I choose two groups. One group are the intervention or the active group where they will have the coffee, and the other group will have the other substance that I want to compare with. I let them have the drink and measure their blood pressure. And then after time, I check their blood pressure again. And if I notice that there is, say for instance, rise in the blood pressure in the two groups after time, after they had the coffee and the other drink, and if I find that the blood pressure rise is not similar in these two groups after time, I can calculate the difference in the rise, and that difference in the rise between the two groups is the what we call the effect of the drinking coffee. And I can say, well, the rise in this group was because of coffee. So coffee can lead to rise in blood pressure by this much. So this is the treatment effect size, or the size of the treatment effect. Not only that coffee led to increase blood pressure, but by how much? By this much. I can only say that if I satisfy a very crucial condition, which is that everything in the two groups have to be comparable, apart from the coffee. So I have to have comparability in their blood pressure at baseline. So they have to be comparable in the shape of the cup, the timing of blood pressure measurements, who took the blood pressure, how was it measured. All these issues have to be similar, and the population themselves, their age, their everything should be similar, apart from coffee, which is different between the two groups. Only if I can achieve that condition, I can then confidently say any change in the blood pressure difference between the two groups is because of the coffee. How do we achieve that comparability? By doing certain set of conduct or certain procedures or methods in the trial which will make absolutely sure that this comparability exists. We randomize people to the two groups. We don't deliberately, knowingly put them there. We conceal their allocation. We don't know who had coffee and who didn't have. We conceal them from them as well. They shouldn't know. The researchers, the assessors, and so on. These conducts methods will help us give us comparable similar groups. What's the difference between concealed allocation and blinding? These are two concepts that are used and you can cross them frequently. Differences in the timing. Anything before allocation treatment is called concealed allocation, and anything afterwards is blinding. The same concept is that not knowing what's happening, but if there's before, it's usually called concealed allocation, and if there's after, it's blinding. What happens if these processes that we do to achieve comparable the groups at baseline, if they were not done properly? We use something called bias. And beyond the literal meaning of what bias is, in clinical research, it is an error in the conduct of a study. What will that lead to? That will give us results which are deviating from the true results or the true value, which means the results are not accurate, they are not true. The key here is that this error in the conduct is systematic, is not one off, is not just a mishap, a one single mistake, a systematic error in the conduct. Depending on where that happens, we have types of bias, and depending on where it happens through the life of a clinical trial or a study. Selection bias, performance bias, detection, attrition, and reporting. And we will go through. Selection bias, the systematic differences between baseline characteristics of the groups. So the groups that we have in the study, they're not similar in certain characteristics. This is introducing selection bias. How to avoid it? By doing randomization, sequence generation is called, and by allocation concealment treatment. How to find evidence for the paper? Description and the methods, and in the results when we have the table of baseline participant characteristics, such as this one. A table like that, usually the first table in every RCT paper, will give us the characteristics, like here in the first column, and the proportion of these characteristics in participants in each group in the trial. And what we want to see is that the proportion of these characteristics are comparable. Not 100% similar, of course, but comparable, so that we can safely say there are no major differences. Randomization or sequence generation will achieve groups that are similar at baseline in their characteristics, but only if the sample size is large enough. If there's a small sample size, even if you do randomization properly, you are unlikely to get really similar. You are likely to get different groups. And a point to remember is that no matter how sample size you will get in a trial, randomization will never completely eliminate the selection bias, but it will minimize it. Performance bias are systematic differences between groups in the care provided other than the intervention. So, how much time you spend with participants in the groups? What do you tell them? What do you do for them? Everything that is provided, the attention, the care, should be similar between the groups. If there are systematic differences, if people in the control group always had less care and attention, and people in the active arm always had more care and attention, then that will introduce what's called performance bias. How do you avoid that? Blinding. If you don't know which participant belongs to which group, then it's likely that you will do the same for both. And so if you blind participants and personnel, then you are reducing the risk. And where to find evidence for it? In the methods, a description of the intervention, and that will assure you what was actually done in each group. Detection bias is if there are systematic differences between groups in how outcomes are determined and measured. So, if the outcomes are measured differently, if the blood pressure was done differently, repeatedly in one group, but just one off, if it was done sitting in one group while in the other group was done standing, or using different machines, and so on, then this will lead to detection bias. And how to avoid it? By blinding or masking of outcome assessors so they're not aware uh, which group they are assessing the outcomes for. And that will help reduce the detection bias. Where to find evidence for it? In the methods section, because this is where the outcome assessment is usually. Attrition bias is differences between the groups in the withdrawals from the study, either by excluding the participants for whatever reason, so the researchers exclude them, or attrition that the participants themselves withdraw and the data is not available. How do you avoid it? You really want to make absolutely sure that it doesn't happen in the trial. You don't want to exclude, and you don't want participants to stop involving in the trial or responding to questionnaires and so on. So you want to address the reasons, explore them, monitor to make sure everybody stays on the trial. Where to find evidence for it? In the methods, in the analysis, and you want to see how, what is the sort of the rate of patients staying and all that. And you find that detail in the study flowchart, such as this one for an RCT. From the top and down in the middle of the flowchart, you will have people randomized into two arms, and then in each arm you will have detail of the numbers of people were allocated to that arm and how many of them stayed, how many withdrew, and why, and over time. And what you want is not exactly similar numbers staying as they're allocated. That's very unlikely. People will drop out for whatever reason. But what you want is the dropout should be comparable in both arms, not more people, many more people dropped in the intervention or in the control compared to the other. If there are differences in the attrition, then that's a problem and that will introduce attrition bias. And this is another example of a flowchart. What happens now when you have attrition bias? Obviously, that will leave you with data not available from people who did not complete the trial for whatever reason. And there are two ways to deal with that, either with what's called intention to treat analysis, in which all participants in the treatment groups are analyzed as randomized. You assume they stay there, there are missing data there, but you will take that and you analyze the data which is available and you still count those people who did not complete the trial. Now, this is very common in pragmatic trials, and the issue will be there is missing data. And what do you do with missing data? That will be a problem because that will affect your overall results. And one way to deal with that is by what's called imputation, in case you've come across this, which is replacing missing data with assumed data based on various sort of statistical methods, taking into account the remaining or the people who completed the trial, and you imputate that. This is used in pragmatic trials because that's what happens in the real world. People don't always complete the treatment, take all the treatment, do exactly what you tell them. And when you do a trial like that, you account for that and you accept it because your results really represent what happened in the real world. The other way of doing that is per protocol analysis, in which you just analyze people who remained and completed your protocol. That's what's called per protocol analysis. And everything which left the trial didn't complete, then you remove them from the analysis. This is not uncommon in explanatory trials, trials which want to find answers of what happens when people take the treatment, complete the treatment, or take the treatment exactly how recommended, and they look at the outcome there. The problem with that, of course, is that you can imagine that this will lead to sort of risk of bias because people are excluded after randomization, and so the groups are not anymore similar in the trial, especially if those who sort of uh, uh, lost to follow up or did not complete the trial are more in one arm than the other or have certain characteristics. And that will introduce problems such as confounding, meaning that you can't be 100% sure that what happened to the outcome in your trial is entirely because of the um, treatment you provided. There might be other factors, especially if, for example, uh, more people left in the intervention because they were not happy with the treatment, they had side effects of the treatment, or they got much better and they didn't want to continue. That will really confound your results. Reporting bias is another of types of biases in which there are systemic differences between reported and unreported findings. That is, researchers selectively choose which outcomes to report. For instance, they only report significant outcomes or outcomes which showed positive results and ignore or not report outcomes which were negative. Of course, you can imagine this leads to bias. How to avoid it? Well, you really want to report everything that you set out to report and to study. And when you find evidence for that in the methods, results, and trial protocol, because that will help you look at what the outcomes the trialist decided to select and study, and you want to really match that with the results to make absolutely sure that this is what they set out to do. These types of biases, the common five, and these are the areas here how to avoid them or what to look for to satisfy yourself that this bias is minimum in the trial. This is all put in what we know now the Cochrane risk of bias tool. So it's really the same types of biases we talked about, and you have the domains looking for areas to check or to test for the presence of these biases. The same, but in text, and you can find this online. You don't need to worry about reading it all here. And this is how the results or a summary of the result of the Cochrane risk of bias tool are presented in a grid. To the left of the grid, you will have a list of the studies that were assessed. And underneath the grid are the domains, random sequence generation, allocation, concealment, and so on. And for every study, this or each domain is assessed from the information in the study. And then the study is scored for that domain, either positive, meaning satisfactory, meaning low risk of bias, or scored negative if the information suggests that this domain was not satisfied, was not done properly, meaning there is high risk of bias, or if there is no information or information incomplete or not clear, then it's unclear. So you can see, for example, study number 1, BEST 2007, scored positive, positive on the first two domains, negative on the next, and then positive on the other, and so on. Another information you can get from visually just looking at the grid is that it gives you an idea of, for example, if you look at the domain, so you look at blinding of participants and personnel, it's been scored negative for all the studies here, which tells you that none of these studies were good at avoiding blinding of participants and personnel, which introduced high risk of bias. And even in outcome assessment, only 2 studies scored positive. So not only for every single study you can have information, but it will give you an information on if you have a review like this one, systematic review of a number of studies, it gives you a feel as to what is the problem or the positive issues in the overall quality of the studies that you looked at? What is the risk of bias here? And put in another way. So in this slide, the bottom, you have the grid, which was the same like we had before. And on the top is the summary, which I am talking about. So you look at, for example, the selective reporting or reporting bias. The bar is all green, meaning all the studies scored positive. So in the bottom half a grid, you can see number 6, which is selective reporting. All the studies scored positive. And up in the bars, 100% of the studies, including the review, scored. And then the unclear is yellow and the high risk of bias is red. So the top of the slide here give you a proportion of the overall studies included in the review as to what is their risk of bias for these domains, not for individual studies. The lower half is for individual studies. So this is just to familiarize yourself with how these results are presented in papers. And this other example is very similar. The principle is exactly the same, but the way these grids are put left, right, and center and turn sometimes can be confusing, but the principle is exactly the same. Once you have a look, then you know your way around it, and then you can read it properly. What is confounding? Confounding is the presence of characteristics in participants that influence the association in your study between the treatment you give and the outcome. If I give coffee, which is the treatment, which is the exposure, and the outcome, which is my outcome of interest, which is blood pressure, I want to have everything nice and comparable between the groups. So there is no noise, no influence, nothing else is happening in the way. So I can confidently say the change in pressure is because of the treatment. If there is any characteristic in the groups that would interfere and will make me unable to say that's because of the treatment I give, that is confounding. And we will come to explain this in a minute. There are three conditions we need to think about, and we will have an example to explain these to make a characteristic to be a confound. So, confound is a characteristic, so remember this is participants, characteristics, or a feature or something there. It should be associated with both outcome and exposure. It should be unequally distributed between the study groups. If it is equally distributed, then this will not influence the outcome, but only when it is unequal. And it should not be the effect of treatment. So it's not like the treatment causes the characteristic. That's not confounding. Now, so if we want to look at a question of whether alcohol drinking causes heart disease. So we will have two groups. We want to compare them. One group, we want them to be people who drink alcohol. And the other group, we want people who don't drink alcohol. And we follow them up over time. And then we record the incidence of heart disease in the two groups. And we want to find out whether people in the group which drink alcohol are more likely to have heart disease, more incidence of heart disease in the group compared with the other group who don't drink alcohol. And then if we have that, then we can safely say, well, drinking alcohol is associated with heart disease or can lead to heart disease or can cause heart disease. Now, if we look at the characteristics of people who were in this study, one of the features are smoking. And we want to check on that because we want to find out whether smoking's got any role, whether a role here, whether smoking is causing a problem, is a confounder or not. Well, we know that smoking is involved in the causation of heart disease. There is evidence for that. We know also that there is some correlation between smoking and drinking. People who drink tend to smoke. But alcohol drinking doesn't cause smoking. Smoking doesn't cause it. So there is no sort of smoke. It's not like alcohol causes smoking and smoking causes heart disease. There is nothing which suggests that smoking is in the causal pathway between alcohol and heart disease. The third condition is whether there is unequal distribution of smokers between the two groups. Now, we have two groups of people in the study, those who drink alcohol and those who don't. If we looked and asked how many of them smoked, and we have similar proportion, then that's fine. The question becomes a problem if we found out that in the group who drink alcohol, many of them smoke as well. And in the group who don't drink alcohol, many of them don't smoke. If there is this unequal distribution, that becomes a problem because we can't anymore safely and confidently say that the incidence of heart disease, which if we found higher in the alcohol drinking group, we can't safely say that's entirely because of alcohol, because there is a smoking there as well, which is unequally distributed between the two groups, which is correlated with both outcome and exposure. And so smoking here is a potential confounder. You can apply the same if you talk about other factors such as gender, body weight, or other factors. If they are distributed equally between the two groups, that's fine. But if they are not equally distributed, then they become potential confounders. What's the difference between confounding and bias? Well, the concept is similar. We're all talking about an equal distribution between the two groups, leading to deviation from the true results. So the concept is similar, but the slight subtle difference is that bias is to do with the conduct of the study. So you talk about selection bias, performance bias. Confounding is the outcome of it. We worry about bias. We think bias is bad because it leads to confounding. Confounding meaning it leads us to results which are different from the truth. You will come across concepts which are internal validity and external validity. What is this and what's the difference? Well, all what we talked about so far is called internal validity. So it's about the risk of bias, it's about confounding, it's about the conduct of the trial, it's all about the internal world or atmosphere in the trial. What was done in the trial? Was it done good? Is there a risk of bias? That's all about internal validity. Do we believe the results of the trial? Is the trial internally valid? These are what we look for in the Cochrane risk of bias tool. Looking for biases, that's the internal validity. External validity, or the other word, generalizability, it's just as it says. It's now beyond the trial itself. Is this relevant to the outside world? Is it applicable? Imagine you have a trial and you checked for biases and it's all perfect. But it was done among, for example, healthy volunteers, 30 to 45-year-old healthy volunteers, and you've got the results. Is this now relevant to your patients, to your real world? You might say it is not. If your patients in the real world are patients who have other diseases, illnesses, not in this age range, they are not healthy individuals, then you really can't say this trial, which was perfectly well done trial, internally valid, you can't say it is externally valid or generalizable because this will not apply to your patients. And what we really want, you want a trial which ticks both these boxes. You want it to be robustly done, well done internally, but you want it to be as externally valid, as generalizable, as representative as possible of the outside world, of the real world. This is a very challenging and a tough task because you try to be as close as possible to the real world, but you will end up excluding patients still who are in the real world, but you really can't include them in your trial. So you see, when you look at trials and you look at the exclusion criteria, for example, people who don't speak English, people who are pregnant, patients with mental health which make them vulnerable to be involved. Now that's all valid thing to do. It's okay because ethically maybe it's a problem to include these in trial. Fine, but then when you have patients out in the real world who have these features, who have this mental illness will be vulnerable, and we look at trial that you have then to say, does this trial result apply? Can I use that treatment for this patient? This is a judgment you have to make, and that is what external validity is. And thank you.